we're gonna, my name's Ali Beheshti. This is the Survive and Thrive series #2. This was regulatory compliance. This was actually asked for at our first one. They said, could you please make the second one about this, because there's a lot of concerns regarding, am I compliant, what licenses, what type of accreditations should I have, how does it affect reimbursement? So I brought Keith Fowler as a guest speaker because he does licensing. And I myself will, when he's done talking about the licensing and accreditation, talk about how licensing and accreditation affects reimbursement rates. And it's mostly based on what policies you can take for what services you can provide. And I will go into that after Keith discusses two primary things. One, incidental medical services license in the state of California. Doesn't exist in some of your other states, so don't freak out when you hear how arduous it is. And then Joint Commission accreditation, which does exist everywhere. So you may freak out at that one if you're in another state. So let me just get started. Like I said, I'm Ali Beheshti. I'm the CEO and founder of Zealie. I actually came to this business because my other sister, who's not here today, is a medical director of a few facilities. She started her own treatment center about 6 years ago, you know, from a doctor's perspective. And then I ended up becoming the CEO of that company, getting into the revenue cycle management side because I realized how deficient the space was in regard to, you know, I have a law degree, so I noticed how some of the legal compliance issues in regard to payer rules, CMS guidelines, and things like that weren't actually properly adhered to, and was causing a lot of financial difficulties for the clients in this space. So we ended up starting our own revenue cycle management that's now pretty much based off of data analytics, which we'll talk about later and how important that is as well. Like I said, we'll start, we did the introductions, and I'm going to let Keith take over, talk about that, incidental medical services and Joint Commission. And then I'm going to talk about requirements for inpatient facilities, requirements for outpatient facilities regarding those, the pros and cons, and some of the solutions we have here that can help you. So with further ado, with no further ado, I'm going to introduce Keith Fowler. The way I know Keith is actually that company I mentioned that started 6 years ago with my other sister. Keith was the guy who got the state licenses, got the state credentialing, and did all the regulatory compliance, and did the packets. So I've known Keith for quite some time. He's done, I don't know, hundreds maybe at this point.
58 the last 4 years.
58 in the past 4 years, licenses with the state, also Joint Commission accreditation, incidental medical services, Department of Healthcare Services, other states as well. So he's helped a lot of our clients that started in California to expand to other states and get credentialed and licensed in those states and get their accreditation in those states as well. So it's definitely, we have a lot of similar clients. We refer him oftentimes when we go into a state where we really need to make sure we adhere to everything. So Keith has been excellent in that regard. So I'm going to switch over to his presentation, which is hidden behind this. Get this out of the way. How do I get under it? Right.
Just barely.
There we go.
There we go.
Okay.
And I'll try to figure out the clicker situation.
Yeah, so you just use the arrows. It's not rocket science.
Cool. All right.
So why don't you introduce yourself?
Yes. Hey, everybody. My name is Keith Fowler, and I'm the founder and CEO of Beverly Consulting Group. And worked in behavioral health since 1991. Obviously, I'm a
sorry, they cannot see on the video.
Oh, here, come on,
Where Ali is, that's where, yeah, that's exactly.
Okay, perfect.
There you go.
Okay, good.
That's
I like the backside view.
Yeah. So I've been in the field since 91. I'm a counselor by training. And I've owned and operated treatment centers, sold my treatment centers in 2015, and started Beverly Consulting Group. And Beverly Consulting Group, we do licensing, certification, accreditation, startup services like pro formas and budgets for people looking to enter the space. As I mentioned, we've done just shy of 60 licenses and certifications. We've operated in 6 different states so far, and done numerous JCAHO accreditations as well. So what I wanted to talk about today, first off, is the incidental medical services. Well, it worked, yay! Yeah. So incidental medical services. Let me just back up for a second. So In the state of California, if you were licensed through the Department of Healthcare Services for a detoxification and residential treatment program, prior to the passage of the Incidental Medical Services Bill, which is AB 848, you could literally just type in AB 848 California and the legislation will pop up for you. Treatment centers really were not supposed to provide medical services for you. We worked within the subacute space. Doctors were not allowed to go to the facility. The expectation was that you would transport patients to a doctor's office, have them get their physical.
We can mute people.
Yes.
I'm going to mute everyone.
Yes.
And then,
We're going to mute you guys. Sorry about that. So if you have questions, just type them. I'm going to mute you. I can just go through and mute everyone.
Yeah.
Okay, keep going.
okay, so once you had your history and physical in the doctor's office, medications could get called into a pharmacy. The facility would go to the pharmacy, pick up the medications, bring them back to the facility, get them squared away, yada, yada, yada. Obviously, this created, a significant impact, both in terms of wait times for a client to be able to be seen. If they're experiencing active detoxification symptoms, it put a hold time on their ability to get their initial medications. And then also really, you're transporting them to somebody else, to a physician, when, as we know, physicians are part of our team. So I'm very grateful that AB 848 passed. Here's the thing about incidental medical services. The regulations for IMS have yet to be published from the department. So when, we kind of took our first crack at this for fun and see how all this would work, we literally took the legislation and then just began to write best practices according to those regulations, and kind of go back and forth. Our IMS packet now for policies and procedures is about 75 pages long. Hopefully the department will be able to publish formal regulations to the provider community soon. It's funny, I was just talking to Ali about this. I called the state and I was like, how many facilities have IMS? They haven't actually started to track those numbers yet, so we don't actually know. But we think it's somewhere in the neighborhood of about 25 or 30 facilities that have secured IMS in the state of California, with a bunch more that are in the process of having. So IMS basically allows a medical practitioner, which would generally be a physician, maybe an osteopath, or his or her designee, such as a nurse practitioner or a physician's assistant, to actually come onto the program premises and be able to provide basic medical services. They distinguish incidental medical services from other full medical services that might be rendered or received in a medical clinic, an urgent care clinic, those kinds of things. So this is really fairly limited in its scope. I'm kind of covering that already. So what does it allow you to do? Like I said, it allows you to have your licensed provider come onto the premises and be able to initiate. And that final sentence is really important that I already mentioned, but the services rendered must be relevant to the provision of alcohol and drug services and not be outside of the scope of non-medical alcohol and drug treatment facilities, such as hospital-based detox programs, medical clinics, emergency rooms. IMS is not a replacement for primary care or specialty care services, right? So we're not doing blood transfusions. We're not doing IV medications. We're not doing rapid detox. We're just doing some real basic medical care, which was prohibited in the state of California prior to the passage of IMS. So what are the essential elements of IMS? So this is directly from the legislation. So first and foremost, obtaining medical history and the use of an examination room. So the examination room is critical. I get calls weekly about the examination room dynamics, if you will, or what it's supposed to basically look like. And so all of us in here, I'm assuming, have been to a doctor on an outpatient basis, and we go in and get our checkup. So if you can imagine walking into your doctor's office, you're generally going to see an exam table and You're going to see medical supplies. Doctor's always going to have a sink for his or her usage, and all of that stuff, right? And that doctor is generally going to be obtaining your medical history. So that initial H&P, which also was helpful in this era of insurance. 90% of what we're doing is insurance-based work. So being able to get that initial assessment is critical, so you can actually do that on the day of admission. So being able to have a properly set up examination room, have the physician be able, in privacy, for him or her to obtain the medical history. Secondly, IMS allows you to monitor patient health status to determine whether the health status warrants transfer to the patient to urgent or emergent care. So, in many of our treatment facilities, maybe you have a nurse or something like that, or a lot of times they're kind of in a office that might be a shared office with technicians or support staff, and people may be coming in to get a pack of cigarettes or to make a phone call or to do any number of things, right? So that IMS exam room really allows for people to have privacy, right? So we're not only doing initial evaluation, but we're doing ongoing evaluation, right? So the nurse can actually bring that patient into the IMS room and conduct, kind of a system by system analysis of those withdrawal symptoms, because it might very well be that a person who arrived upon admission looked one particular way and looked that they would be able to receive oral medications and do detoxification in a residential treatment center, but their symptoms have increased to the point that that no longer is the case. They might be an alcohol withdrawal delirium. They may be, maybe their respirations have dropped to an unsafe level. So being able to have that examination room, you're able to conduct that exam in privacy and then determine if that person needs a higher level of care without disruption and without compromising confidentiality. Testing for the presence of alcohol and or drugs. So obviously, for people that would be doing some testing, you'll need to also have a CLIA license. That's another subject for another day, but it allows for the provision of testing for the presence of alcohol or drugs. In addition to that, it is allowed for people if they want to have an intermuscular injection, or if there needs to be a blood draw. Maybe they're going to be, checking other issues that might be going on. Maybe wanting to kind of check liver function tests, or do HIV testing or hepatitis testing. All of that is called for in the IMS office. Once again, not wanting to exceed the standard of what should occur in a medical clinic. So programs are responsible to make a determination. Wow, the doctor's really wanting to do stuff above and beyond what we can do, and that does require some level of judgment. And then providing alcoholism or drug use recovery or treatment services. I think that's going to happen less and less in the IMS room, but being able to provide client education. Maybe the nurse is going to talk to a patient about issues, and they can receive alcoholism and drug use recovery or treatment services there. Overseeing patient self-administering of medications. So the IMS passage does not allow for nurses to dispense medications to patients, right? We are still bound by the same set of subacute standards where, the patient must, self-administer their own medications. Now, they must be supervised by staff. We want to make sure that the client is prompted to, it's, every every 4 hours, not 4 every 2 hours, and, kind of make sure that they're taking medications according to prescription, but they still need to be the ones to self-administer. Treating substance use disorders, including detoxification, that it's a little bit of redundancy, but that really is talking about medications, exams, maybe doing a CEMA, all of that's appropriate within the IMS office. Application process. So really two different categories, right? A lot of programs, have been licensed for a long time. They may be looking to add the IMS to their existing license. So in that scenario, which is actually the second sentence, existing organizations would complete the application for additional services and submit the fees, which is just a little over $1,000. So it's well worth it. And the application for additional services, it's basically 2 pages. It'll take 5 minutes for you to, print it, fill it out, and be able to mail it. New facilities would utilize the initial application for licensure or certification. I would highly recommend doing that. That way you're only getting 1 site visit, both for your initial license and for your IMS. Because if you're doing it as an additional services, that will trigger for them to come out, do a physical inspection of the IMS room. And of course, everything's open to them taking a look at. And then of course, fees. So if you're currently licensed and you want to add it to $1,034, but if you're a new facility, nothing, completely free, because you're already paying your initial application fee. So, why wait, do it while the iron's hot. Questions so far?
How much is the initial application fee without the?
It is, I think it's $2,987, right around $3,000. Yeah. Application, so we just talked about that. Facility renovation. So this is where I get the most amount of questions in regards to the IMS room. So it does need to be a separate room. So for many 6-bed facilities, especially if it's an existing facility, people have kind of opened up their treatment centers based on the fact maybe they have one shared office that, their support staff as well as their case managers maybe utilize, or maybe they have one other office for the therapist or case managers. Unfortunately, the IMS does require a separate room. As we talked about, first and foremost, you need a proper examination table with sanitary disposable covers. And the examination tables, you can get a Hyundai or you can get a Bentley. I've looked, Amazon, you can get it for $200, or you can get, a very large, heavy 400-pound, exam table with, cool drawers underneath and everything else. It's, $2,000. So really just depends on what your budget is. But at the end of the day, just a standard examination table with sanitary disposable covers. Medical supplies. I'm going to hold off on that real quick. A fresh water supply. So they're going to need a sink in the room with both hot and cold water, with the hot water running between 105 to 120 degrees Fahrenheit. I usually get an old school thermometer under the tongue and just, let that run for 3 to 5 minutes. Make sure you're hitting a minimum of 105. You're not going over 120. If it is going over 120, call a plumber, have them adjust, or if you're familiar with your hot water heaters, just, dial that down a notch and you should be good to go. I have yet to hear of a situation where an IMS is passed when it was like a master bedroom with a bathroom kind of adjoining. I'm assuming that might work. I haven't done that yet. Everyone that I've done, it's actually, physically in the room, so there's no having to leave the room.
For the same.
Yeah, for the same, exactly. Yeah. Medication cabinets. Medication cabinets that are locked. Patients do self-administer their medications in the presence of staff. Separate cabinets are also in place for additional medical supplies not requiring a locked cabinet. So, my recommendation and what I have seen so far is to literally just close your eyes and set that up like your doctor's office, right? You've got your exam table. Over here you have a, desk and chairs, overhead cabinetry for your medical supplies, and then a separate locking cabinet for your medications. So all of a sudden your IMS room does become your medication room. That really is kind of the purpose here, right? So it would free up other space in other parts of the facility. And once again, you have to have the double lock, right? So you need to have a lock on the door, lock on the cabinet. And then I'm always a big fan of the triple lock, so the separate locked medication box for your narcotics, right? Just to give that extra layer of protection. Sharps and hazardous waste containers. Incidental medical services does allow for the provision. If a nurse maybe is going to give somebody an intramuscular injection or to check maybe a diabetic's blood sugar, that obviously is, provokes universal precautions. And so having a sharps container, big red boxes, dropping that in there when you're done, setting up, and then I would recommend setting up an account Stericycle, because they'll just come directly, pick up those sharps containers, and then swap them out for you on an as-needed basis. Medical equipment, such as my favorite word, an otoscope, which is a little thing with the ears and the doctor looks in. Thermometers, stethoscope, blood pressure cuff to assist the physician or his or her designee with the completion of the medical history. So once again, just kind of set that up like your doctor's office, right? First aid kits, and then the room is enclosed with permanent walls for adequate privacy. That should be self-explanatory, but once again, you're not throwing up a little pony wall and trying to call that guy INS office. They want to full enclosed. And then the IMS room has cabinetry, as we talked about, for storage medical equipment and supplies in a separate locked cabinet for meds. Questions so far? Reason right there. Okay, so let's see. So JCAHO, this was the second part of it. So yeah, we wanted to talk about JCAHO. First off, what is JCAHO? Because I always see people mess up the initials. It's the Joint Commission on Accreditation of Hospital Organizations. And JCAHO is the largest national accreditation body. Their standards are applicable to all healthcare organizations. So whether you're a hospital, clinic, pharmacy, behavioral health organization, JCAHO has a standard for you to follow. They identify standards. There's a million standards, but basically these are the categories in which you're going to have to get prepared. And then underneath each of those, there's a number of sub-standards that are there as well. So and that's going to encompass care, treatment, and services, emergency management, waived testing, and once again, if you're going to be doing waived testing, you need to have CLIA to be able to follow through with that. Rights and responsibilities, that's as it relates to patients. Performance improvement, your record of care, documentation, national patient safety goals, life safety, leadership, information management, HR management, and the environment of care. So, JCAHO is the biggest. When I first got in the field, when Keith Miller first got in the field, CARF was the standard. And so I get hit as a consultant fairly often. Do I do CARF? Do I do JCAHO? And Ali is going to have more up-to-date information on some of this stuff. But CARF is the Commission on Accreditation of Rehabilitation Facilities. So when I started working in residential treatment, it was all about CARF. And why? Because CARF is entirely focused on residential treatment and is really geared towards whether you're a group home, whether you're a residential treatment center, it's all geared towards residential care. JCAHO, to the contrary, is about medical care hospital organizations. But once again, it is the biggest, and it has surpassed CARF in terms of the size, what providers are generally looking for. CARF is still a national standard. I still pull for CARF. But obviously, JCAHO has really surpassed that. With CARF, there's about 45 organizations that kind of do what we do in the substance abuse space. And similarly, they also have standards, just like JCAHO. JCAHO's standards are more what's the word? Comprehensive, I guess would be the word, than CARF. But CARF is no walk in the park as well. They have a lot of standards also. Requirements to apply for JCAHO. You have to be licensed or certified to provide the service that you are seeking accreditation and in good standing with the organization's licensing body. So I put that in there because I had a call a couple weeks ago. Somebody had a licensed detox and residential treatment center, and they were providing outpatient services, but they didn't have certification for the outpatient center. By law of the state of California, you can't operate an outpatient center without an outpatient certification. But it's pretty hard to bill insurance that way, number one. And number two, they're not going to be able to apply for outpatient services with JCAHO because they don't have certification. So you want to make sure that, and there's all kinds of different categories for JCAHO accreditation that you can apply for. So if you want to say, if you want to hit, maybe 5 service areas, you want to make sure that you're already providing all of those services, you're already certified and licensed to this extent to be able to, to then hit up on the accreditation side. How long does it take to become ready to apply? I get that a lot as well. So an organization may apply at any point as long as they feel by the time of the survey they can demonstrate compliance with all standards. General recommendation are for organizations to have 6 months of compliance before the survey. Just a note, that is my professional opinion. You basically have to have 3 to 4 months of demonstrable compliance with the standards by the time of the survey for them to get your JCAHO. So I have lots of organizations call me, hey, we're going to get licensed on Wednesday. Can we apply for JCAHO on Thursday? It's like, well, I mean, at the end of the day, yes, you can if you choose a survey date, because that's an important thing with JCAHO. You actually pick your survey time frame as opposed to state. But do you think organizationally you're prepared to meet and fulfill all of these standards and have that demonstratable with all your committees, your notes, and everything else? So it's my professional opinion that, yeah, get licensed, begin to immediately buy the books, register on Joint Commission Connect, and then begin to implement a compliance program so that you're implementing these things. You're not killing your staff. Organizationally, you're getting more ready and more ready. And when you feel like, okay, you've been doing this for 6 months, then send it off. Why? Because when the Joint Commissions comes, you're going to be able to demonstrate with pride that in all of these areas of standards, you're there, as opposed to, them coming and you might not be able to demonstrate those standards, and then you're going to have a very long correction report. And and the thing is with JCAHO, they can give you a 1 year, they can give you a 3-year accreditation. So you always want to shoot for that 3-year, when and where possible, and performance is what's going to dictate that. So don't be in as big of a rush as everybody says. How long does the JCAHO process take? Like I said, the minimum standards, being able to demonstrate compliance with a period of about 4 months prior to them showing up. And what happens during the survey? Surveyors will evaluate on a standard by standard basis, demonstrable compliance to each standard. At the conclusion of the survey, a series of recommendations for improvement will be given to the organization. I didn't want to go too much in the left field on the JCAHO survey because I could have done 5 more slides on that, but functionally, basically, depending on the size of your organization, your survey could last up to 3 days, depending on your size and depending on what you're applying for. You could have up to about 3 surveyors, depending on the size of your organization, and they would, be looking at clinical and operations, financial and performance and leadership and HR and everything. So. And if you're a 6-bed, then that's going to be a lot quicker, a lot easier, a lot cheaper. Costs vary depending on what you're applying for, the size of your organization. But you definitely want to be financially solvent enough to be able to not only pay those fees, but also you're going to be flying out the surveyors and putting them up and all that good stuff. So how to maintain compliance. This is the most important thing. So it is important to remain in a constant state of compliance with both regulatory and accreditation standards. JCAHO is very good, outstanding actually, about providing annual updates to standards through their online portal, meaning it's published to the provider community. Because maybe you're not due for 3 years, or let's say 2 years, but then there's a new standard. You've been trying to be in compliance with the old standard, now there's a new one. So you want to make sure you're reading all of those annual updates as well. Many programs will have a particular manager or staff designee to act as a compliance officer And it's important to do mock surveys, both in terms of DHCS and JCAHO compliance. I can't tell you as a consultant the amount of times that I get side work because somebody will call and say, hey, we just had our DHCS surprise inspection and our personnel files are a mess, our charts are a mess, and we have done our staff training, we have, blah, 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 right? And so, so we can go in there and clean it up, and, write the correction report and all that good stuff. But it sure is a heck of a lot easier for a treatment facility if you just stay in compliance. That way you don't have to get in compliance, right? If you stay ready, you don't have to get ready. So both as it relates to JCAHO and to DHCS, the importance is being able to stay in a constant state of compliance. And any questions?
There's probably going to be a lot at the end, but
yeah. And then if you guys do have additional questions, I've left my contact information up there. Feel free to call me on my cell phone. Feel free to email me. Website's up there. And thank you so much.
Thanks so much, Gabe. That was excellent.
Yeah.
It was going to be a lot longer. I had him short that. You want to get real technical, so you can thank me for that one. Let's see here. So I'll get into now. I'm going to talk about the financial implications from a revenue cycle management side of what Keith just talked about, why it's important to have all these. And then we're going to eat, so don't worry. I know what you're all thinking when is that going to happen. Mine's going to be shorter, okay? I'm just going to talk about the finances because I'm hungry too. So first, let's talk about inpatient facilities, okay? These are, in fact, the incidental. Go ahead. This way? Okay. So first, I'll talk about inpatient because incidental medical services, what Keith didn't actually touch on, it only applies to detox residential facilities. It does not apply to outpatient. So inpatient facilities, right now, Optum, which administers all the behavioral health, almost like we're talking 99% of behavioral health care services for United Healthcare, one of the largest insurance companies in the United States, to get credentialed as an out-of-network provider, is asking our clients to have an incidental medical services license, which is actually, if you think about it, absurd, considering Keith just said only 25 to 30 facilities in the state actually have it, according to estimates. So this is a very high bar. People are fighting this right now, but as of now, as of last week when I talked to them, it's still a requirement if you want to get credentialed as an out-of-network payer. Now, if you're already credentialed as an out-of-network payer, you're kind of safe. However, letters have gone out saying, hey, it's time to get re-credentialed with Optum, okay? Please send us your incidental medical services license. And then the provider's like, well, we're already credentialed with Optum, and we don't have an incidental medical services license. And Optum has said, okay, you lost your credentialing with us. Call us when you have your incidental medical services license. So people who used to be able to take United Healthcare, one of the best payers for out-of-network providers in the behavioral health space, are now getting hit with this letter. So it's important to get this, even if you're already credentialed with Optum, go ahead and get your incidental medical services license if you're in the state of California. You guys out there in Utah and Texas, don't freak out, Elias and Marsha. This is a California thing, so don't freak out. So that's incidental medical services and Optum. Very important to know. Now, let's talk about Joint Commission accreditation with the other major payers, okay? Almost all Aetnas for inpatient facilities are requiring Joint Commission accreditation. This is huge, right? Aetna is a very good inpatient payer, and guess what? They're the ones that require Joint Commission accreditation, the better paying policies from Aetna also. And many Cigna, United, and Anthem ECBS policies, as some of the people in this room could attest to, are now requiring Joint Commission for out-of-network providers. Some will do CARF equivalent, but just recently, so up until about last year, they would constantly say Joint Commission accreditation or CARF equivalent. This year, we're starting to see Joint Commission accreditation, and then we say, or CARF equivalent, and they're saying, no, just Joint Commission accreditation. So that's really starting to happen where CARF isn't cutting it. So that's one of the things I'm telling my clients is, don't think you're safe just because you have CARF. all of a sudden they're starting to make Joint Commission. And a lot of these Cigna, United, and Anthem ECS policies they're asking for Joint Commission, once again, similar to Aetna, happen to be the better payers. So we're seeing a correlation between better paying policies requiring higher regulatory compliance standards than the lower paying policies, probably because the lower paying policies don't care because they're not losing as much money. The better paying policies are trying to create barriers to entry of taking those clients. And now, one of the things that just recently happened when we went to talk to Blue Cross Blue Shield Anthem to take that facility in network, they actually asked for that facility to have incidental medical services and Joint Commission accreditation to go in network. So now we're seeing a shift. All of a sudden, to go in network, to get to bill certain policies, to do all these things, they're just increasing and increasing the standards because truthfully, they don't want to pay you. So the less policies you can take, the better for them. So they're making it harder and harder. Now, this could be a benefit for those who get these because obviously some people won't go through that time, effort, and compliance standards to do all of these things. So it's to all of our clients, we're telling all of our clients, be ahead of the curve. Don't be behind the curve because this is just going to keep going in this direction. The signs are clear. The writing's on the wall. The more compliance, the better off you are because tomorrow, for all we know, Aetna, Cigna, United, they're going to require higher things. They're going to require IMS. They're going to ask for more and more because that's just how the industry is going. And even now, outpatient facilities. So in California, for example, and other states as well, state certification isn't actually required to open up an outpatient facility. But if you want to take health insurance, the health insurance provider to get credentialed as a PHP or IOP requires a state certification. So since 90% of the business, actually I'd say it's even more now, is insurance business, you got to have that state cert, okay? So that's the minimum for outpatient. But now all of a sudden, we're seeing some new standards. Joint Commission accreditation, again, one of our other outpatient clients that just does PHP IOP, no inpatient care whatsoever, went to go in network. They started negotiating the contract. And again, this was with Anthem Blue Cross. And Anthem Blue Cross came back and said, oh, we just noticed you don't have your Joint Commission accreditation. In the middle of the process, they were already negotiating rates at this point. Cut them off. That was it. They're like, come back to us when you have Joint Commission accreditation. And that was for an outpatient facility. I'd never seen that before. So this was a new thing. Again, standards are getting higher and higher, not just for inpatient. So again, get the higher standard because things are moving in this direction. It's very important for financial reasons, not just compliance reasons, but financial as well. And so, and now we're starting to see policies, which we've never seen before. Again, this has started late last year, early this year. We're seeing trends of out of network, so they're out of network and outpatient. The policies are requiring Joint Commission just to bill. Okay, it's not that many. It's a very small fraction of them. We're just starting to see it. But again, it's a trend. Things are moving in a particular direction. So that's something we have to pay attention to. 2 years ago, if you told me that, I'd be like, that's insane. No policies require that. Now all of a sudden we're seeing it. So it's definitely, everything's tightening up. They're looking closely at this space. So pros and cons of getting either an IMS or a Joint Commission accreditation versus the cons. So pros, the biggest pro, obviously for me, because I'm on the financial side of this, being able to admit more patients with better policies. Because like I said, United, Aetna, these statistically pay very good, relatively speaking to the other payers, and they're also the ones with the higher requirement standards. More authorizations, okay? We're actually seeing more auths because of better notes, because they're creating a system where, especially Joint Commission, where they actually look at your EHR and they look at your notes. And then all of a sudden we're seeing staff members that know that they have to be compliant with these notes and standards when Joint Commission comes in. Their notes are actually getting better. And for us, from an authorization standpoint, it's leading to longer authorizations, which is also financially beneficial for our carriers. And from a practical sense, we are seeing a better standard of care at these facilities because they're constantly working to be compliant with all these standards. So they're more vigilant with standards. And then, of course, the cons, the cost. retrofitting your building. One of the biggest costs that I hear, or says detox res is getting IMS saying, we're gonna lose 2 beds. Because they had a 3-bedroom, 2-bath house. If they wanna get incidental medical services, they're gonna lose a room. So that is a consideration they have to take in mind, or they have to add a room convert, which is costly as well. So time, it's time consuming, right? It's not slow, but it's worth the time. Trust me on that one. Effort. Can you mute more people? I think you're I don't know.
Here's the host.
Okay, so effort. This effort is actually the biggest effort is maintenance. Maintaining those standards. The effort to get past the Joint Commission is pretty difficult, but constantly being compliant, that's where it's coming from. But that effort is worth it because it leads to those pros I mentioned on the other side. So I wanted to talk about, we track here the data analytics, and I wanted to talk about the policies that pay well, okay? This is actually one of our facilities. We've taken out their name and PHL, but this is their data analytics. And as you can see on here, they're getting 60% of their build rate from United. So this is a detox that bills about $4,000 a day, okay? So we're talking about policies, $2,800 a day policies. That's how they're doing with United. Now, if tomorrow they got a letter in the mail that said, hey, it's United, it's Optum, which is United, and we'd like to, re-credential you, but we need that IMS license, and they don't have that IMS license, 17% of their revenue goes away, right? And it's revenue that's, their overhead is, fixed, so that's a big chunk of their revenue, right? Aetna, same thing. If they didn't have Joint Commission accreditation, it's 9% of the revenue gone right off the top. So you combine those two, all of a sudden 25% of your revenue is lost if you're not in compliance. So it's not a small, insignificant sum when we talk about these payers. This is just a heat map across the United States. This shows how policies are paying from different geographic regions. The reason I put this up is we've seen a correlation between the heat map. By the way, this is scrambled data, so don't look at this and be like, oh, we should mark it in this state. This is from our demo app that's got the scrambled data. But this is a heat map from our internal usage that our clients see. And the hot policies from the hot states that we're seeing, the policies from those states are requiring Joint Commission accreditation. So very important, some of these states that are very high paying, that have those good policies, if you're gonna admit clients from those states into your program, those states' policies have higher requirements than we're seeing of states with lower paying policies. So I wanted to show this to you. If you wanna target certain states, and now let's talk about other payers. It's not just those big guys. We're seeing the little guys slower than the rest, okay? But these are also high paying policies. So we track reimbursement rates from everyone in a system called Payer Tracker that actually Pam was here, just recently built out that tracks all the payers across the United States and sees how they reimburse for detox, res, PHP, IOP, and other services related to this sector. And even these smaller payers are now beginning, especially the high paying ones, again, requiring Joint Commission. They're not so much IMS because IMS is very state, California state specific, but the smaller guys are going Joint Commission and unfortunately away from CARF, which I actually do believe is a great accreditation, but it's not what the insurance providers are looking for, so our clients are moving away from it. And again, this is more of the data analytics where we break it down in our mobile app, but if you were to see in here how much, when you type in your unique identifiers, how many of the policies that are high paying require those higher requirements, it's pretty stunning. So the data is pointing in one direction, and that direction is higher compliance for higher paying policies. When you track how much you get paid from everyone, and you start noticing which policies pay good, you'll see they require higher levels of compliance. This is just our verification of benefits system through our mobile application. Also, when you verify, you can find out if a policy, not through this interface, but when you do a hard VOB, you can find out, does it require Joint Commission? Does it require incidental medical services? And more often we're seeing that. So the old way, people used to do business in this sector, and it worked for years. It was called heads and beds. Just fill up your heads. Put as many heads and beds as you can. And you'll do fine. and the margins were high and all that. Now it's about the right heads in the right beds, okay? You have to be very careful what policies you're allowing into your facility, what are the requirements, making sure you meet those requirements, because the high-paying policies are less than they used to be. 5 years ago, Keith, when you first were talking about that, when we first met, we would see anybody would come in, open a facility, let in everybody, and do fine. Including Blue Shield. In fact, Blue Shield of California was a good one. And if you didn't get that joke, that's bad. Okay, that's a bad. You should know that. Do not take that policy. So, and then it came Health Net, and also again, you don't get that. Do not take Health Net. That's okay. So, unless they got a whole lot of cash up front. But anyway, it's about the right heads and the right beds. And the number one reason we see businesses fail in this space is they haven't adjusted to the new way. The new way is more sophisticated. It's more complex. It's more about compliance. More about data analytics. And those people that are adjusting are thriving, while unfortunately those who aren't adjusting, you probably have seen, are not even surviving. A lot of places can't get out of their old bad habits. It's stuck and they just can't make it in this industry. So an offer for everyone here who's joined us today, we're doing a free payment audit. We have the technology here at Zealie to take any of your electronic health records. We don't need any of your billing data and make what are called API calls. We have database access to all the payers, find out what you're getting paid. So you can see those data analytics we were just talking about for yourself to see how much am I getting from every payer, and am I being hamstrung by my non-compliance with certain payers that I could be doing much better on. So we can tell you how much you're making from each payer, why certain claims are getting rejected, why others are getting accepted, why some are paying high, why some are paying low, simply through this audit. And it's pretty easy. You can extract the stuff from your EHR and give it to you. We need what are called API calls to the payers. We spit it out into a data analytics platform, also developed by Pamela. She's getting a lot of credit here. But yeah, any one of you here will do that for, and those of you online, of course, just let us know. You can reach out to us at info@Zealie, or call Carlos, who's also here. His number's up there, and we're going to be sharing this video as well, so don't feel like you have to write this all down right now. We'll send an email with all this data for you at the end. So right now we're going to stop and take any questions.